Good afternoon, dear colleagues, dear participants, and the Bridge International viewers. Our Bridge International group increasing our fields. So today we are deal on surgical andrology. As you all know, techniques of surgical management in andrology are changed a lot in the last decades. And today we will discuss this all new trends and concepts for treatment of erectile dysfunction, Peyronie's disease with our experts. So they will highlight video-based presentations. And dear participants, please feel free and put your questions on the chat, and we will try to answer in the end of each presentation. Thank you. So today I will explain our first speaker. He is a well-known surgeon in this field, Vladimir Kojovic, Associate Professor of the Surgery and Urology, University of Belgrade, and Serbia Andrometric Academy, Belgrade. Today, he will talk and share his presentation on contemporary management of the Peyronie's disease. Dear Vladimir, you can share your screen and start your presentation.
Thank you. First of all, I would like to thank you for inviting me, for giving me the opportunity to be the part of this wonderful group of doctors, of urologists, sharing knowledge, exchanging knowledge worldwide. Thank you one more time. I will proceed to my presentation. So first of all, I would like to emphasize that Peyronie's disease is psychosexual condition. It is psychosexual condition with penile deformity, possible plaque, and sexual dysfunction. It was described by French Dr. Peyronie, so that's why it is called Peyronie's disease or induratio penis plastica. So a peak incidence is between 5th and 6th decades. Prevalence rate is actually very high. It's up to 20%. So it is a widely underdiagnosed condition. Autopsy prevalence is even higher, 22%. So why do we have this increased incidence? Probably because men is sexually active in the older age, and we have increased detection. So it is a very common disease. Still, we don't know etiology. There are some assumptions that repetitive microvascular injury or trauma can cause this delamination of tunica albuginea with bleeding, immune response, growth factor, scarring, and at the end, after calcification, we have dense and strong plaque as a final stage of this disease. So in our office, we usually see patients with penile deformity, penile shortening, and painful erections. Some of them have erectile dysfunction. There is difficulty or impossible intercourse, and we can feel hard mass on palpation. Typically, we have two phases. First, acute phase, where we can have pain. Patients complain of pain, enlargement of plaque, worsening of deformity. So usually it lasts about 12 months. And after that, it's stable. This is stable phase. So it's plaque is calcifying. There is no more pain, and deformity is stable. In some cases, we can see improvement. It's up to 13%. But usually we see progression and finally stabilization of this disease. So first, we need to have a very thorough medical and sexual history on our patient. We need to perform physical exam to assess the plaque, stretch and rectal penile length, degree of the curvature. And of course, we need to perform intracavernous injection with PGE1, prostaglandin 1, to assess the degree of penile curvature, additional deformities, rigidity. So there are some complex cases with B-plane deformity, hinge deformity, corkscrew, hourglass deformity, etc. We can also perform ultrasound to define the size of plaque and to see flow parameters. MRI only in atypical clinical cases like this one here. There are several questionnaires. Standardized is International Index of Erectile Function, but it is not related to Peyronie's disease. And we have Peyronie's disease questionnaire, which is becoming popular, but still it's not so common in everyday clinical practice. We all know that there are some comorbidities with this disease. Typically, we have the Dupuytren contracture. Still, we don't know if there are some contribution of these comorbidities or risk factors to pathophysiology of this Peyronie's disease. We need to be careful to not misdiagnose this condition with congenital curvature, hypospadias, dorsal vein thrombosis, penile fracture, fibrosis of corporal body, sarcoma, or some metastatic infiltration. Here in this photo, you can see this is MRI of my patient who has some problem mimicking Peyronie's disease, but actually he has angiosarcoma of the corporal body. This is his specimen after surgery. So contemporary treatment can be conservative, non-surgical, and surgical. We tend to follow these guidelines, AUA guidelines, EAU guidelines, and guidelines of International Society of Sexual Medicine. It is very, very important to do preoperative counseling. Thorough preoperative counseling is very, very important. I could not emphasize more because these patients sometimes has, unrealistic expectations. Conservative treatments, you use it in early stage. The main goal of conservative treatment is to relieve symptoms, not to cure the disease. And we try to prevent progression. These are the modality: oral treatment, topical, intralesional, and other procedures. So for oral therapy, it is recommended 5 PDE inhibitors as tadalafil, to help prevent erectile dysfunction, and non-steroidal anti-inflammatory drugs to relieve pain. So this is the only 2 medications that are advised in this oral therapy modalities. All other treatment as vitamin E, colchicine, carnitine, potaba, tamoxifen, pentoxifillin are largely ineffective. That are the recommendation. Topical treatment, verapamil and iontophoresis is not recommended for the treatment because we don't have data about its efficacy. Extracorporeal shockwave treatment, it is good, but it only can relieve pain. It cannot correct the curvature or stop progression of the disease, but it can relieve pain. Fractional vacuum device we assume that it can correct curvature or give some length, but there are limited data on this modality. Intralesional treatments, steroids and verapamil are not recommended in the treatment of Peyronie's disease. Interferon can help reducing curvature, plaque, or pain, and one of the most effective intralesional treatment is clostridial collagenase, Xiapex, and it is proved that it can correct curvature and reduce plaque size. So Xiapex is injected into the plaque. There are several protocols, several regimen, 8 injection or reduced regimen with 3 shots, but all of them are, combined with penile modeling, intra-office, office modeling, and modeling by patient in their home. Stretching activity and straightening activity between shots of collagenase Clostridium. So that is recommended, and there are actually many data, many published papers by known doctors dealing with this problem, with good results of these treatments, and usually they conclude that these data show benefit in patients with penile disease and penile curvature between 30 and 90%. This is a less invasive approach compared to surgery. This curvature improvement is not as significant as in surgery, but we can offer this treatment for our patients who are not willing to do surgery, who are not amenable for surgical intervention, and they prefer conservative treatment. Unfortunately, Xiapex is removed from European markets, recently in the last year. So we still we don't have now some regimen, some protocol, some medication that we can, offer our patients for this intralesional treatment. We will see maybe in near future they will some some other pharmaceutical company maybe will offer some alternative to this Xiapex medication that we had. So for non-surgical treatments, as I said, do not offer vitamin E, Pataba, tamoxifen, etc. Only anti-inflammatory drugs and 5-FDG inhibitors. That's what I offer actually to my patient. Extracorporeal shockwave treatment only if they prefer this treatment to reduce pain. All other treatments are not recommended. Some traction device and vacuum device can help a little bit, during, especially in the early stage, because we are actually waiting for stable disease to realize if we will go do the surgery or not. Surgical treatment, as I said, we need to wait for a chronic phase of the disease and to have a stable deformity at least 3 months. Some also advised at least 6 months, but we tend to wait at least 3 months. There need to be stable deformity. There are 3 types of surgical procedure: penile shortening procedures, lengthening procedures, and penile implants. So this is simplified algorithm for surgical treatment of Peyronie's disease. First, we need to realize if the patient has or not erectile dysfunction. If there is erectile dysfunction, the only solution for the patient is penile implant. If there is no erectile dysfunction, we assess the degree of the curvature, concomitant deformities as hourglass deformity, complex curvature, corkscrew deformity, or if there is severe shortening of the penis. If all this is present, we need to do penile lengthening procedures. So this is graft surgery. If there is normal length, sufficient length of the penis and smaller degree of curvature, we can offer our patient penile shortening procedure. So that's plication. This is simplified plication procedures, as Nesbitt or Yahia. It's simple, it's fast, and there is less risk of erectile dysfunction. Contrary, we can have a penile shortening with this plication procedure. So these are candidate: mild curvature, preserved penile length, no erectile dysfunction, and no complex deformity. This is very well known Nesbitt plication procedure, or Yahia, published many years ago. And recently 16-dot procedure published by Dom Lu. It's also very popular. And this is one intraoperative photo of plication procedure. Second option is lengthening of the shorter side of the penis. So we use grafts. We can restore actually penile length, but it is challenging surgery, demanding surgery, and there is possibility of postoperative erectile dysfunction. There are many grafting materials published in papers. The most popular bovine pericardium. There were published papers with saphenous vein, tachocomb, buccal mucosa graft, and SIC, small intestine submucosa, porcine dermis. Generally, it's recommended to be natural graft, not synthetic graft. So this is one grafting procedure using bovine pericardium, lifting of the neurovascular bundle, grafting, and postoperative appearance. It's another one with some calcified plaque attached to the neurovascular bundle that need to be removed. Opening of the tunica and complex grafting procedure, and appearance immediately after grafting and reattachment of the neurovascular bundle. We also can use TahoSeal several times. There are some papers published on this material. It's not proper grafting material, but it is material that can close this wound in tunica albuginea. Postoperatively, we always advised our patient to use tadalafil, vacuum, and stretching device, and in that way we prevent shortening of the graft that can happen. There are some complications of grafting procedure. As I said, erectile dysfunction, de novo erectile dysfunction can be found, especially in severe curvature, where when we use huge graft, we can have residual deformity, residual curvature. rejection of graft, infection, like on this photo, we can see infection and the graft need to be removed. And we need to tell our patients that they can have altered penile sensation after this surgery. So to conclude, we use graft technique in patients with stable disease, with bigger curvature, with short penis and complex deformity as hourglass deformity, and preserved erectile rigidity. There are no ideal grafts that can be recommended, so all depends on surgical experience, careful patient selection, patient preference as well, and type of penile deformities. All this, need to be assessed before making a final decision of the type of the procedure. And finally, penile implants, penile prosthesis is used where we have penile Peyronie's disease combined with the erectile dysfunction. We have semi-rigid inflatable penile implant with several manufacturers on the market. So with this implant, we need to assess the residual curvature. We will correct the erectile deformity, but we need to assess, residual curvature. So we need to do penile modeling, plication, or grafting. So this is one of the procedure where we do a penile implant without grafting, but we made multiple incision of the tunica to release and to gain length and to straighten the penis. After surgery, we put an inflatable penile implant. This is one patient where we do penile modeling. As you can see, we use penoscrotal approach in this patient because there was mild curvature in postoperative photos, and malleable penile implants with penile modeling. There are some geometrical principles published by GDO. If you use graft, this is also some new methods for correction of the Peyronie's disease as sliding technique, modified sliding technique, or multiple slit technique. You need to be very careful because there are several published data about glans necrosis after this surgery. So this is combined clinical guidelines, and as I said, this is simplified guidelines about surgical treatment. I will not, repeat all this. So you have three actually options for surgery. You need to assess your patients. There are some new perspectives about correction of penile and disease as Peyronie's disease. It's also, of course, it's tissue engineering. There are some published data about human penile scaffold. So we are waiting for new horizons and new approaches in this treatment. So to conclude, this is psychosexual condition. We need to make thorough patient counseling to meet all patient expectations. There are no effective oral treatment. We can only deal with pain and erectile dysfunction. No effective topical treatment. Sapex was useful, as I said, but there are no more Sapex on the market. So only effective treatment is surgical treatment of penile deformity and erectile dysfunction. So we cannot cure this disease, but we can make full restoration of penile function. At the end, I would like to send all of you regards from Belgrade and our Andromedic Academy. Thank you one more time.
Here's no questions on the chat because of the availability of your information, maybe. But I have one question. So we all know that connective tissue and autoimmune disorders. So some diseases like deep routine in orthopedics and like a scleroderma. How often this kind of patients we can meet, and do we check up every patient for this kind of disorders? How is important?
Well, thank you for the question. So we usually see about 1/3 of this patient having some, usually it's dipytria and contracture, So usually we ask them to show their hands, or they, complain immediately about having this problem. But we still don't know if there is some connection, between this disease. But definitely, it is systemic disease. As you said, this is disease of connective tissue, And clostrate collagenase was actually used for DP3N contracture, and it is still on the market, for DP3N, but it was, removed from the market for Peyronie's disease, probably due to, reported problems with the tunicle rupture and some additional, complications.
And it will not change any tactics of our surgical treatment, right?
Yes, I don't think it will change, but it was a good option. Intralesional treatment was a good option for a patient with a mild disease, for a patient who are not willing to do the surgery or unfit for the surgery. So I tend to offer them this treatment, intralesional treatment, penile modeling, to help reduce penile curvature. We still don't know about placebo effect. Maybe simple penile modeling can help them, correct the curvature. But we are waiting for a new medication on the market to offer our patients who are not willing to do the surgery.
Thank you, Vladimir, for your kind presentation.
Sorry, I can ask one question.
Yes, of course.
Vladimir, thank you for a good presentation. We know much grafts in Peyronie disease, but I like vena saphena. What graft do you like?
Well, my experience, I have the extensive experience of bovine pericardium. So bovine pericardium, it's my graft of preference, you can discuss about, financial moment because it is, usually patient need to pay for this graft, but bovine pericardium and small intestine submucosa was also very, very, very good. It is a thinner, and but there are some reports that SIS can have a bigger rate of contracture after surgery. I actually don't use skin or vena saphena. I tend to use this bovine pericardium grafts. Several manufacturers on the market, and usually we have some of this on the stock.
If we have no another question, so we will move to our second presenter. Thank you, Vladimir, one more time.
Thank you.
For presentation. Thank you. So our next speaker is Pier Andrea Della Camera. He's Chief of Urology and Andrology, Leonardo da Vinci Hospital, Florence, Italy. So the topic of presentation is sexual recovery after radical prostatectomy, what we do and what we forget.
So, and I want to show you how we treat this kind of patient. So, this is the uro-oncology surgery that determine erectile dysfunction, and as you know, radical prostatectomy is one of these. This is some data about the incidence in Europe of the cancer, the prostate cancer, but I don't want to boring the audience. And this is the incidence of the prostate cancer in Tuscany. So when we treat a patient with prostatic cancer, we have to think about two items: the oncology radicality and the quality of life. Because we understand that it's important to preserve the nerves during the surgery. But it's important, the quality of life, because according to our study published a lot of years ago, we can say how this patient survived a lot of years. So with the Da Vinci technique, we can preserve the nerve, and we have a good continence rate. In Florence, we have about 5 Da Vinci robot, and with robot, as you know, we can have a lot of degree of the freedom of the movement of the hands, and we can preserve nerves in a better way. So we speak about now we speak about the pentafactor factor, that the item are about the continence, the erectile dysfunction, the control of the disease, and to avoid the adverse event and the surgical margin. So Da Vinci robot is a machine technique that give to us the possibility to have a good rate of continence, a good rate of erectile dysfunction. But nowadays there are no contraindication to treat a prosthetic cancer with robot technique, but according to our experience, some caution should be taken if we have to treat prostate of large volume, prostate with a third lobe, and prostate that had a previous transurethral surgery and in high-risk patient. According to new meta-analysis, it's not important the technique that you use, but it's important the experience of the surgery. So I am a robot surgeon, but this meta-analysis, according to our experience, it's a correct meta-analysis because our result is similar to the result of this meta-analysis, because in Florence some surgeon performed open prostatectomy, some other laparoscopic prostatectomy, and some other robotic prostatectomy. And the most important thing is the experience of the surgeon and not the technique that he used. So what is the aim of sexual rehabilitation after nerve-sparing prostatectomy? After the nerve-sparing prostatectomy, we have the increase of collagen fibers, and this is related to the impossibility to our patient to have a good erection after the surgery. Especially in the first month after the surgery. So there is an increase of fibrosis, and this leads to a veno-occlusive dysfunction. So our aim is to increase the oxygenation of the corpora cavernosa and to avoid the increase of collagens in the penis. What do we do in Florence? In Florence, we are very, very lucky because the national healthcare system pay all the medication and all the device that our patient need to have a good sexual recovery after the radical prostatectomy. So this is one of the way to give the tablet to our patient. PDA5, according to our experience, is the base of the sexual recovery. But in Florence, we don't like on-demand way to give a tablet to our patient. This is other way to give this PDA5 to our patient. And this is the Montorsi way to give PDA5 with 5 milligrams a day, but in our experience, we have no good result with this way. Or Hartmut Post way to give PDA5 with 5 milligrams a day, and the Avanafil on demand. This could be an option in a patient that have some side effect with tadalafil at higher concentration. So in Florence, generally, we use a chronic way to give tablet to our patient, and we prefer tadalafil 2 or 3 times a week. According to our experience, 3 times a week that for you could be an over-treatment of the patient, but we have a little better result in our patient, and we start the administration of PDA5 when we remove the catheter after the surgery. We have no better result if we start the PDA5 before the surgery, like some other study published in literature. So this is one of study that I will show to you that speak about the usefulness of avanafil in a chronic therapy after nerve-sparing radical prostatectomy. And in this study, I speak about the chronic administration of the avanafil that could be an option in a patient that have side effect with tadalafil or, for example, with sildenafil, because avanafil have no side effect or a very little percentage of side effect. So, but tadalafil or, for example, PDA5, it's the base of our treatment. We have to advise our patient that PDA5 it's only a little part of his recovery of the sexual of the erection. So it's important to advise to our patient a corpora cavernosa gym. So why is important to advise our patient a corpora cavernosa gym? Because in the first part of his rehabilitation, the first part after the surgery, he have no good erection, and for this reason, it's possible an hypooxygenation of the corpora cavernosa. So this is a slide that I show to my student, and this slide, because for me, the patient after the surgery is like a strong car, but in this strong car, we damaged the link to the engine. For this reason, when our body restored the link, our car now is a very old car, and for this reason patient have no good erection because he had no good erection from a lot of time. So vacuum device is the first device that I want to speak with you, because for me is very similar to the physiotherapy after an orthopedic surgery. You can use the vacuum device with the aspiration and to lead the patient to have a good direction, and sometimes patient have to reduce the pressure into the device, and he have to repeat this movement, and I speak of the physiharmonic way to give an erection to the patient. And we have to remember to our patient that vacuum device is an instrument that he can use if sexual recovery don't have good result. So there are a lot of experience of the use of vacuum device after radical prostatectomy from 1986, but sometimes we forgot to advise this device to our patient. And then in patients that have no good erection, even in nerve sparing, even if the patient performed nerve sparing radical prostatectomy, if this patient have no good erection, we advise the intracavernous injection of the alprostatil, because with this injection, patient could perform a stretching of his penis, and we can allow our patient to have a sexual intercourse. So this is an option that we have to remember, the possibility to add alprostatil cream with PDA5. Generally, alprostatil cream can give another hand to our patient to have a good erection. I want to show you this study in which we used alprostatil cream in radical prostatectomy patient. So in this study, we had a good result, but we have to advise our patient that alprostatil cream not ever have a good result. Sometimes alprostatil cream have a good result, but some other time alprostatil cream have no important result with classic penile burning in our patient. So this is a study that I showed some years ago in a congress in Italy when I speak about the shockwave therapy. So in this patient. These are patients that performed a radical prostatectomy, not a non-nerve sparing radical prostatectomy. These patients have no chance to have an erection with the PDA5 because we damage the nerve for the erection. This perform a radical prostatectomy. So in this patient, we perform shockwave therapy, and in this patient, we see that after 1 month, this patient reduced the dose of the alprostatil injection that they performed to have an erection. So shockwave therapy have a rule in the sexual recovery after prostatectomy. So testosterone, this is a very difficult argument to treat because some of us, some urologists, studied a lot of years ago that the use of testosterone in hypogonadic men can lead to cancer tumor. But nowadays, we know that in hypogonadic men, testosterone don't lead to prostate cancer. But in radical prostatectomy, if you see the European guideline, you can see that that the use of testosterone have an important contraindication in metastatic prostatic cancer in a patient that have locally advanced prostate cancer. But if you see the European guideline, you can see that you have some caution to give testosterone in a patient that have a high risk cancer tumor, even if the patient performed a radical treatment locally, but you can give testosterone after radical prostatectomy if the patient have a low risk grade, a prostatic low risk grade, and if the patient performed a radical surgery. So in Florence, this is another study that support, as I say to you, and generally in Florence, in low-grade hypogonadic men who performed a radical local treatment, and in the patient that have a normal PSA at 2 or 3 years after the radical prostatectomy, we give testosterone because, as you know, testosterone increase in hypogonadic men the rule of the PDE5 inhibitors. So this is a sentence of an important architect, Ludwig Mies van der Rohe, that say less is more. According to our experience, less is less and more is more in penile rehabilitation, because we have to remember that the base of the rehabilitation is the PDE5, but we have to advise our patient that have to use the vacuum device, and eventually the penile injection of the alprostadil or alprostadil cream, and with some caution we can give in hypogonadic men testosterone. And as we say in Italy, the cherry on the cake is the shockwave therapy that in some patient can give a little hand to increase the erection. Thank you for your attention, and you can contact me on my website, on my YouTube channel, or my email.
Thank you, Pierre, for excellent lecture. It is very informative. So, in our chat, I have one question. I will add something from myself. So, despite the extent of various therapeutic alternatives for treating erectile dysfunction, but a proper algorithm or clinical guidelines that could enlighten us regarding the proper management of the post-prostatectomy erectile dysfunction. And now has not been established, no any algorithms. So question was, now, do we have any specific algorithm for this kind of problem?
Oh, it's very difficult to respond to this answer. So generally, we start with a long-active therapy. So in a non-nerve-sparing radical prostatectomy, we use generally tadalafil. That if the patient have some adverse events from tadalafil, so we shift this patient to sildenafil or avanafil. Avanafil have a very little percentage of side effect, but avanafil doesn't work like tadalafil and sildenafil. And we prefer tadalafil because with tadalafil, a patient don't have the link between administration of tablet and sexual intercourse. So this is important for the psychological effect of the medicamentation. So if I follow the European guideline, I have to give to my patient tadalafil 2 times a week. But we see that if you give 3 times a week, you have a little percentage better of patient that respond to the therapy. But in all patients, we advise vacuum device, because vacuum device give this stretching of the penis and avoid the reduce of the length of the penis. So if this patient after 2 months, 3 months, or 4 months have no sexual intercourse, we can advise to our patient alprostate, we can add to our patient alprostadil injection or alprostadil cream, because with this medication, patient could have a sexual intercourse, and the patient do a stretching of the penis. And if the patient is compliant, we perform shockwave therapy, but shockwave therapy have a no very good importance in this rehabilitation. If a patient have a good motivation, is a patient that want to follow us and want to perform all technique, we can add shockwave therapy. But the base are PDA5, better if you use tadalafil, and vacuum device. After, you can add some other, for example, alprostadil injection, alprostadil cream, or shockwave therapy, if patient have no sexual intercourse after 2 or 3 months after the surgery. And some patient after, for example, 1 year and 1 year and a half, stopped alprostadil injection or alprostadil cream, because you can remember to our patient that sexual rehabilitation can take 1 or 2 years, is very long. According to our experience, you can see the most percentage of the rehabilitation after 1 year and 1 year and a half. After 1 year and 1 year and a half, it's difficult that the patient increase his erection, but we have to wait. We advise penile prosthesis after 2 years or 3 years, because we try all. If a patient have no good erection after 1 year and a half, we use shockwave therapy, alprostadil injection, all. If this patient have no good erection after 2 years, we advise penile prosthesis.
Okay. Thank you for your answer.
Thank you to you. Thank you to you.
Enjoy your vacation, and it was very nice to hear you and very nice presentation. Thank you.
Thank you to you.
Dear participants, I will explain our next speaker. He's Dr. Gautam Banga. He's from Delhi. He's a reconstructive and urologist and andrologist. So today he will explain his experience on the intraoperative and postoperative complications and management of penile prosthesis. So Dr. Banga, it's your time.
Thank you for the introduction, and a very good afternoon from Delhi, India. I know we all are going through a bad phase of COVID. I would always prefer a physical meet than a webinar, but this is a time, so we have to go with this. Okay, so the topic I'm catering today is the penile prosthesis, difficult situation and complication. So we all are doing penile prosthesis on our daily practice, and most of the time the situation is very easy. The dilatation is easy. The penis is straight. We can easily place the implant and get out of the OT with a big smile on our face and a smile on the face of the patient after a few days. But my teacher used to teach me that you have to be very careful with the organ which are single in the body. Most of the organs are to number hand, leg, kidneys. So even if something goes wrong with one, we can manage the things with the other one. But the single organ, whether it's heart, brain, or penis, we have to be very, very careful. So difficult situation can be encountered before surgery. It can come during surgery, and post-surgery complications are always there with any kind of surgery. But yes, with penile processes, we have to be very careful, because if we lose the penis, there is no alternative. We cannot get it back. So what are the situations which we can encounter before surgery? The patient comes to us with erectile dysfunction. We treat them with medical management, not responding, Doppler done, vasculogenic, neurogenic. We plan for the prosthesis. And just before we have scheduled the things for the OR, we find the patient's having infection. So infection is a totally no-no thing. If we find there is a local infection from the site where we want to do the procedure, we should definitely postpone the procedure. Second condition is when we encounter a buried penis, that the penis is totally entrapped, whether in the fat or in the scar. So can we combine both the surgeries? Well, in few cases we can, but in majority of cases it's a bit difficult, and sometimes we have to stage the procedure. And we have to release the penis. We have to do liposuction, suprapubic region. We sometimes have to do a pubic lift, and implant can be placed in the second stage. If the patient is having phimosis, we need to evaluate whether it's just a tight frenular band, or the patient is having a defined full-fledged phimosis with the peripheral skin totally adherent to the glands. And we have to sometimes combine circumcision along with the penile process implantation. How to do with the patient with the hypospadias? So in my practice, uroflowmetry, residual urine through ultrasound, and if required, retrograde ureterogram is mandatory whenever we are planning a patient with any history of catheterization or structural endoscopic intervention or a hypospadias, to check the urine passage, because urethra is any day more important and more utility-wise compared to the erection. And if the patient is having congenital curvature and penonis, though most of the things have been covered by Dr. Vladimir, but I'll just go through them. I'll brush through them over the few next slides. So we should know which all implants are available in the hospital as well as in the country, because not all implants are available everywhere. Few countries have some implants available, the other are not there. So in India, when it comes to inflatable implant, we are getting Boston Scientific, which is the AMS series, and Coloplast off and on is available. So we cannot totally rely on Coloplast. And if it comes to inflatable, we always put AMS series. Semi-rigid implant, we have one indigenous Indian implant by name of Sharp Prosthesis. Then we have Coloplast Genesis, and we have Boston Scientific Tectra now. Few other are in the market, gradually making a space, like Regicon, implant from Zephyr and Tube. But still, the availability is very less, and so we are not very much preferring them. So we should know what size of implants are available, which one is for corporal fibrosis, which one we can place to increase the length. A brief knowledge about that is a must when we are planning to go ahead with the implant surgery. So when we see a patient with a short penile length and a penile curvature, how to deal with that? So patient always want a bigger thing. They always want big, better thing. But we have to see how we can help. We cannot just put 1 kg material in a half to 500 gram packet. So a 500 can be accommodated in a 500 gram packet, not a 1 kg, 1 kilogram. Yeah. So surgeon should be aware of available penile length and the girths. We should always measure the stretch penile length whenever the patient is in the outpatient. We should check it multiple times, say 2-3 times, and we should always consult the patient that this is a stretch penile length. And when we put the implant, the best of the implant, still the length which he's going to get is a stretch penile length, not the erect penile length which he used to have earlier. So the counseling matters a lot. Otherwise, patients are very demanding, and once they come out of the OR, they always say, "How much length I have got, doc? Is it like the same which I have when I was having normal erection?" And then you don't want to say the truth, but you always tell a lie. Yes, you've got the same length, but that's not the truth. So that's why it's always better to inform them, guide them, and everything should be on paper. Ask the patient about curvature of the penis. So most of the patients say we don't have curvature. Doc, it's just a small bend. But we should always look for a plaque because that's going to change the procedure completely. Dr. Vladimir already told that we need to correct the curvature. We need to correct the plaque. We have to remove the plaque if you want a straight penis. And we should always ask the patient if they have any picture of erection. Even if it's a mild erection, we should see whether there's a tight superficial skin, whether there's a curvature, whether there's any other deformity. We should always check that. So coming to penile curvature, thing already covered. It can be in the form of mild curvature of 15-20 degree, 25 degree curvature, moderate, 25 to 45 degree curvature, and a severe curvature. So the modality of correction varies with the severity of the curvature. So penile remodeling, once we place the implant, we inflate it to the max. And then we do a penile remodeling maneuver in which we completely bend the penis for around 15 to 20 seconds. And it's meant for mild curvature. And in most of the cases, it leads to rupture of the plaque. If it's a very small plaque, it normally ruptures. And we can achieve a straighter penis after this maneuver. But in some cases, it doesn't lead to full correction. And in my opinion, if it's a 5 degree, 10 degree curvature, the patient is pretty okay with that. They don't want a perfectly straight penis until unless the patient is too young and want to impress many girls. Otherwise, most of the people are happy if they have a mild curvature, but it should not be too much so that it can lead to extrusion or any further injury to the corpora once they start doing the sexual activity. So if it is a moderate degree curvature, we do plication, already the Nesbitt plication explained by Vladimir. So we do that and it leads to decent correction, and then we can always place the implant post-plication procedure. So if the curvature is of a higher grade, it's more than 30, 40 degree, so then we can place any kind of implant. We can place both inflatable as well as semi-rigid prosthesis. And we normally put the implant first and then the plication can be done. But in a semi-rigid, we do implantation of the prosthesis through the same incision, same place from where we have removed the plaque. And after placing the implant, we do grafting. So penile curvature already have been, these are various techniques, the sliding technique, multiple slit technique, and the grafting can be done by various grafting material. In our practice, in most of the patients in whom we place penile prosthesis, we use tensor fascial atta. The good thing about tensor fascial atta is a tough grafting material, easily available. We can harvest a very good amount of tensor fascial atta from one thigh or both the thighs, and it doesn't contract much. And patient in our study, we have done around 26 patients, and they are doing very well with this grafting material. Otherwise, you can always use bovine pericardium. It is available, but it costs around $500 in India. So if you want to cut down the cost, we always use tensor fascial atta. But if the patient is ready to pay, we can always use bovine pericardium. Now coming to the incision. So which incision should be preferred? There's one pinoscrotal incision, the other is infrapubic. Pinoscrotal can be a longitudinal incision or a horizontal incision. Well, there's no such defined thing which one is better and which one is not better. All the incisions depend upon the surgeon's preference, and they can go with any of the incision in which they are more comfortable with. And in my practice, I always use a vertical pinoscrotal incision with a 3 centimeter incision. The whole procedure can be completed. I'm pretty comfortable with this incision. But yes, if you feel that you need to open the fascia for placement of the reservoir, you can always go with the infrapubic approach. But yes, you should be well versed how to go ahead with that approach. Otherwise, if you have any confusion, you still not ready which one to be taken, always go with the pinosportal. So these are the ways by which implant can be placed by two different incisions. Again, the incision that is the infrapubic incision, and the other one is a pinosportal. So coming to the intraoperative complication. So most of the intraoperative complication occur during the dilatation. Since that is the most important part of the surgery of dilating the corpora, because placing a reservoir and placing a scrotal pump is pretty simple things, but the most important thing is the dilatation of the corpora to the right length, to the right girth, and to the right size. Is very important, and we have to be very careful when we are doing the dilatation, because if it goes wrong, in most of the cases we have to stop the procedure, and difficult to go in for surgery again in such patients if the perforation is very big or there is a urethral injury, because since we have done the dilatation or partial dilatation, now the injury has taken place, and if we will not complete the procedure, the chances of fibrosis during the second stage will be very, very high. So the different problem can happen. So we should know where to place the corporotomy. It should not be too lateral. It should not be too close to the urethral margin. So what are the problems we can face when we are dilating the corporal space while before placing the cylinders? So difficult dilatation can be due to corporal fibrosis. We can encounter a distal perforation, distal to the dilatation site, or a proximal perforation towards the crura, and a urethral perforation. So these are three ways by which we can encounter perforation while doing the corporal dilatation. So what are the patient factors which can lead to these kind of problems? So if the patient is diabetic, patient has taken intracameral injection for the erectile dysfunction for a long time, patient having Peyronie's disease or have been injected with verapamil or cholinesterase or some other steroids, and these kind of patient can have a lot of fibrosis, because when we try to inject into a plaque, 50% of drug goes into the corpora, because we cannot be so correct in injecting into the plaque. Or if the patient is having history of prolonged ischemic priapism, nowadays our threshold for going for implantation has come down a lot. We put implant as early as possible in a ischemic priapism. We don't wait for 15, 20 or 30 days. If a patient comes to us with a priapism even of 4 or 5 days, and a shunt have been attempted and still the patient is not able to have a detumescence, we always go ahead with the implantation in such patients. Any prior prosthesis infection, which I've already mentioned, that if we stop it in the first stage and plan the patient for the second stage, the chances of difficult dilatation is high in the second stage. Or the patient is having any history of trauma. I've seen many patients with PFUIs, pelvic fractures, after the urethral injury have been treated, and most of these patients have vasculogenic kind of erectile dysfunction. And when I have gone inside, I face a lot of problem in dilating these patients, because most of these patients have fibrosis because of no vascularity, and most of them, and in many patients, I placed a small caliber implant in these to provide them a good erection. So how we can manage these kind of patients whom having a lot of fibrosis? So we have to strategically decide where exactly to place the corporotomies. A single corporotomy sometimes is not sufficient for dilatation, and we have to do multiple corporotomies. We have to move from one to the second to the third, and slowly and gradually we have to make space for the cylinders or the implants. We should always have these dilators, that Euromix or Mobile dilators, which are meant, which have we have to use in an oscillating or a drilling kind of method, and you can create space in the corpora. We don't have that because the set is costly. It's not available. So we are trying to procure one set of that, but no, still date we don't have, and we have to rely on other methods by which we can make space in corpora for the cylinders. So we use scissors in most of the cases. We use a long scissor. We try to go all the way up to the distal corpora and the proximal corpora, we open it up and try to make space for the cylinders. In few cases, I have used Otis euthrotome. If we find that the fibrosis is very dense, we can use Otis euthrotome, but we have to be very careful that we should not be opening the blade towards the urethra. Otherwise, we can land up in a very devastating condition. Counter incision already been mentioned that we can make multiple corpotomies and dilatation can be finished with that. So corporal counter incision, multiple incision with minimal scar tissue excision, that is in the case when the scar tissue is less and we can easily make a space. But if the scar tissue is almost occupying the whole corporal body, we have to open the corporal body, we have to do like an excavation of the corpora, wide excision, like a core, we have to remove a core of fibrous tissue from the corporal bed. And sometimes once we place the cylinder, we are not able to close the corpora, and we have to use various graft. It can be a dermal graft, it can be tensor fasciolata, which we use. And if it's a short defect, we can use buccal mucosa also. But the tensor fasciolata give us a good length of graft, and we can cover it with that. So this is the technique which we use, scissor and Otis euthrotome. These are the various dilators which are meant for corporal fiber dilatation of the corpora when there's corporal fibrosis. And this is the way it works. These are the multiple corporotomies which have been done, moving from one to another to third, and to make some space for the cylinders. And in most of the cases, we are able to place a small caliber, like the CXR or a narrow base cylinders in these kind of patients. Now coming to the second problem or a complication which can happen is the distal perforation. So once we started dilating the corpora, and we find that once we measure it, there's a discrepancy in the measurement, or when we are dilating, there's a sudden loss of resistance during dilatation, or a penile edema appears during distal corporal irrigation, or there's a migration of the distal cylindrical tip to more proximal shaft. So these are the indicators that the dilatation has gone wrong somewhere, and it's time we should check it. So we have to put dilator on both the sides and see whether the one dilator is going out and the other dilator is normal. And we can always repair. If the distal perforation takes place, we don't have to terminate the procedure. We can always make a small incision at the site of perforation, and we can repair that distal perforation, and we can go ahead with the implantation of the penile prosthesis. So this is the way we can check whether both the dilatations are of same size and there is no perforation. Both the dilators are lying at the same level, and and we can also say that the dilatation is complete on both the sides. Second is the urethral injury or perforation. So when we are dilating and the dilatation angle is more towards the medial side, and sometimes what can happen is that the dilator, if you're using a small caliber dilator, it can straight away come out of the meatus, or a blood start coming out at the meatus. And when we push fluid into the corpora for irrigation, we see that the fluid is coming out from around the urethral catheter. So these are the very clear signs that some urethral injury has taken place. And the best thing is to stop at that moment, abandon the procedure of penile prosthesis insertion, and open the area where you are suspecting the urethral injury, repair the urethral injury, and do a diversion procedure like suprapubic cystostomy. Wait for 2-3 weeks, let the urethra heals off, and then you can go in again and put the implant. Third thing which can happen is the proximal perforation. This is very common in patient who is having priapism, because in priapism, if you're going with the early implantation, you have to be very careful with the dilatation in a patient with priapism, because the tissues are a bit friable. So we have to be very careful while dilating. We have to use slow dilatation, and it should be a very gradual rotating dilatation, then straightforward pushing the dilator through the corpora. Second scenario in which this kind of perforation can take place is in the patient who have been operated for pelvic fracture urethral injury, and they have done crural separation to as a part of the progressive perineal urethroplasty, and they have done a crural separation. So the direction of crura changes a bit, and if you're not very much aware of this step being done earlier, we can damage or we can perforate the crura on the proximal part. So if there is a perforation some perforation has taken place in the proximal part, we can always use a mesh, whichever mesh is available with you. Even a small hernia mesh simple hernia mesh can serve the purpose. So you can just make a sort of a cap for the lower part, and you can put it there. And you can, with the help of a Prolene or non-visible suture, you can just fix it with the corpora. So all these things have already been enumerated, that most of the time the perforation take place in the initial step of dilatations. And if perforation take place, you just put one dilator on the other side and start dilatation on the other side. Once you complete the dilatation on the normal side, you can put a bigger dilator on that side and then start doing the dilatation for the side which according to you have a perforation. Okay, so in some cases, crossover can take place. Like you started dilating the right corpora, according to you have completed the procedure, and then once you place the implant on the left side, you're not able to place the cylinder or the implant on the right side. So in those cases, we have to be careful. We have to see whether there's any crossover taken place. Most of the time, crossovers doesn't need any kind of repair, and by placing dilators on one side, we can place a cylinder on the other side. But if you feel that the defect is more, you can just make a small opening at the side and can repair the septum. So this is the way a crossover can present. Now, when we are planning to put the reservoir, that is most of the time, in my case, I use a pinoscrotal incision. So the positioning of the reservoir is more of a blind procedure. Or you can use a nasal speculum, make a space, and then you can place the reservoir. So problem which we can face while putting the reservoir is that we try to open the fascia, but the fascia is not getting open. Or when we have opened the fascia, we are suddenly into the bladder, or we have injured the wall of the bladder when we are using a long artery to make the space. Vascular injury, though very rare, but can happen. And peritoneal perforation and opening. Well, I have encountered a one bowel injury while placing the reservoir for the sphincter. The patient was having previous pelvic surgery, radical cystectomy, and with a new bladder. And I tried to make the space, and all I can see was the green colored fluid coming out from the wound, and I was in a fix what to do. So I abandoned the procedure and made a control fistula there, and it healed over a period of time. So post-operatively, the complication, if we placed a 100 ml reservoir for the longer penis with 18 or 21 or 24 centimeter length cylinders, patient can have a venous compression syndrome. It's with a small pelvic cavity, herniation of the reservoir, or inguinal herniation of the intra-abdominal content. So this is through an infrapubic approach, and this is an easier approach when you're putting the reservoir because everything is in front. But when we are doing through the pinoscrotal incision, it's more like a finger dissection and more of a blind procedure. But in most of the cases, you can manage through pinoscrotal incision. So things which you have to be careful is that there should be you should take in account any previous robotic surgery or radical cystectomy surgery, any abdominal surgery, or if the patient was having any pelvic radiation or history of any urinoma after anastomosis. So what you can think or you can do is that you can put ectopic, you can use ectopic position for reservoir placement, that is between the transverse abdominis muscle and the transversus fascia. And in the rarest case, you can always place it above the muscle also, just below the subcutaneous tissue. The third aspect of implantation is making a scrotal pouch. The most easiest part of the thing, but yes, most of the hematomas starts from the scrotal darter's pouch formation. So we have to be very careful that there should be proper hemostasis. The pouch which you create the skin should not be too thin over that area, or should not be too thick. If it's too thick, it will be very difficult for the patient to feel the pump, to feel the deactivation button. And if it is too thin, there's always a chance of skin necrosis and scrotal pump extrusion. So once we have placed the cylinder, we should fill the reservoir and we should check the cylinders. That is meant to check for the length as well as proper dilatation, or you can say dilatation of the corpora. If we find any curvature, we can do remodeling. And if we feel that one corpora is erect, the other is not, we should always rule out crossover of the cylinders. And remodeling can be done at this stage. And we should always cycle the cylinders 2 or 3 times before closing the circuit. So this kind of problem can happen, that you have placed everything and you started the inflation deflation and the pump collapse. So this happened when there is air inside the system and you close the thing and the air got stuck in the valve and you're not able to deflate it. Sometimes when we are overzealous, we think we can finish off the thing fast. You have to remember that penile implant is a delicate thing. It's not like a metallic implant which orthopedicians use, and that's why the orthopedicians have those biceps and triceps, because they have to drill those implants. But we have to be very careful. These are delicate things, and it bears a lot of cost. This thing happened when we try to push the lower end of the implant in a not very much dilated area, and we use an inserter to push it, and eventually it led to damage to the tubing, and we have to go for another implant in this case. So post-op management, once we place the implant, we use a compression bandage for 48 hours to prevent hematoma. We use a scrotal support. And some people use mummy style dressing, but we don't use that. We just put a creep bandage compression bandage around the penis, and we keep the implant inflated for 24 to 48 hours. And after 48 hours, we deflate it to 25%. And then after a week time, we totally deflate it and start the cycling of the implant. So what all post-op complication can happen? Infection, it's a very vast topic. I'm not going to touch that. It can be discussed in another presentation, because that leads a lot of protocols, and whether to keep the implant, whether to remove the implant, can we salvage the implant or no. So all we can discuss in the next presentation. Other thing which can happen is erosion into the urethra. If there is an injury which has taken place during the dilatation, but the mucosa is intact, sometime when the patient start doing the cycling of the implant, and with the pressure of the implant, the erosion takes place and implants come out of the urethra. And it can also be because of the misdirected implant placement. Erosion of the scrotal pump, I already told you, if we make the scrotal pouch, subdarter's pouch, very thin, and after usage, after certain time, patient can have thinning of the skin, and this pump can extrude from there. Concord deformity, S-shape deformity are badly placed cylinders or miscalculation while measuring the corporal space. Malfunctioning of the implant, well, as I showed you, one thing in which the air was there in the system and in the circuit, and that can happen. But in most of the cases, though these people say that the implant runs for 10, 12 years, but I've seen most of the patients start developing some kind of malfunctioning by 6 to 7 years of implantation. So this is a Concord deformity in which a short size cylinders have been placed undersized and leading to drooping of the glans downward. So floppy glans syndrome is one thing which can happen, where a patient can present, in which the cylinders are perfectly placed, but the glans is soft and moves from side to side. So most the theory which has been proposed for this is that the cylinders are not big enough to compress the veins, and so the glans turgidity or the glans tumescence doesn't take place, and so the glans is very floppy, and doesn't support, doesn't sit properly over the cylinders. So whether to teach the person to pull the skin downward while doing the sexual activity, or you can go ahead with the upsizing of the cylinders. But bit of tricky situation if the patient is comfortable, or if you can do a small plication of the glands to the cylinder, to the corpora, that can also serve the purpose. Flail penis, again, because of the badly placed cylinders, undersized or severely undersized, the whole of the distal penis can be bent, can be moved. And so these kind of patients have very much difficulty while doing the sexual activity. Dorsal deflection, so kind of a reverse ST. So in these cases, we have to remove the implant, or we can do plication and try to salvage the implant. So this way we can we can prevent any impending perforation. If we find that the corpora is getting thinned out, either we can do a double breasting of the corporal tissue, or we can put a dermal graft or a mucosal graft, or even a mesh can serve the purpose. Again, one of the most common problem we see patient coming to us is the oversized implant. There are many young urologists who want to give a bigger size penis. In India, it has again become a very war of words. They keep on telling the patient that if your penis stretch penile length is 12 centimeter, I'll give you a penis of 15 centimeter. How? This is the results of that you try to put in a bigger implant because you want to replicate erectile penile length. But you have to understand that you can keep the penis in an erect state for 24 hours, 7 days a week, 365 days a year. Not possible. Eventually, it leads to a lot of pain to the patient, extrusion, erosion, and breakage of the implant. So this is the result of that when you place a oversized implant, and eventually after a certain time you lead to breakage because the bend is there, and the patient comes for a removal or an implantation. This is a picture showing a badly placed scrotal pump. The skin is very thin, and so almost at the verge of extrusion, and you can see that the skin is getting necrosed. One of the most more rare complication that the tubing erode through the skin. So yes, size does matter. We always want to give the best penile size to our patient going for penile prosthesis. We can always upsize the implant after, like, once we have implanted, we can go for upsize in the next stage. But yes, we have to be realistic with that. We have to guide a patient what best length we can provide them. No unrealistic commitment, no unrealistic assurance, and you'll be safe in your practice. And no, don't try to put in too big implant. Not possible, lead to a lot of pain, and eventually you have to replace it. Various other methods are there. You can release suspensory ligament. Again, I'm pretty doubtful about how much help it can do in increasing the size. You can always do scrotoplasty and make the penis look better than what it was earlier. So again, penile prosthesis is one of the simplest surgery a urologist can do. If it is a good penile length, easy corporal dilatation, 45 minutes to 1 hour, you are done with the surgery. But yes, if the complication occurs, you should know when to stop and how to manage those complications. That's the most important thing. So take home message from this presentation is that it's a game changer surgery, but yes, we have to be careful, and time should never be the criteria that I can do surgery in 45 minutes or 1 hour. It should be a clean surgery, it should be a safe surgery, and it should give or deliver very good results. So yes, penile implant can bring in a lot of satisfaction, and you can be the reason for that.
Thank you. Very demonstrative presentation, and scientific, and very knowledgeable, very good knowledge from your PPT. Thank you for your time. We will move for our next presenter. He's a well-known in Russia professor, Pavel Kozlasov, professor, Department of Urology and Andrology, and head of Urology and Andrology Center, State Research Center. named after Burnazyan Federal Medical Biological Agency, Moscow, Russia. So the topic of his presentation is extraperitoneoscopic revascularization of penis with antegrade connection of the inferior epigastric artery to the deep dorsal vein. So Pavel, you can start share your screen.
Thank you, my friend Azimjon. Hello, everybody. Dear colleagues, in my presentation, extraperitoneoscopic revascularization of the penis with antegrade connection of the inferior epigastric artery to the deep dorsal vein, I want to tell about the approaching of my team to these surgeries. Considering the time we live, we should note the work by Sanson and co-authors. They say 80% sustained COVID, not in the sense of sexual function to a very degree. Endothelial dysfunction, psychology distress, violation of pulmonary hemodynamic, all it contribution potential start erectile dysfunction. Besides, COVID can aggravate cardinal vessels disease that also increase the risk of development erectile dysfunction. A bit about epidemiology. In 2020 in Russia, from 1225 examined, in the age from 20 to 75, symptoms erectile dysfunction was found in 1101 examined. 10.1% had not symptoms erectile dysfunction. 71.3% had light symptoms erectile dysfunction. 6.6% had medium symptoms erectile dysfunction. 12% had distinct symptoms erectile dysfunction. From 1225 examined, 115 finished the sexual activity as for 68.6% etiology was erectile dysfunction. A bit about history. The first surgery was Václav Michal in 1973. He connecting of the inferior epigastric artery to the cavernosum body. From 1973 to recent time, it was suggested more 20 variants of revascularization of the penis. The method of Professor Kovalyov was suggested, who suggested the forming artery-venosus anastomosis age to age between epigastric artery and the main stalk of the deep dorsal vein, more proximal of perforans vessel, with ligation of the proximal venosus edge, combining with the partial venosus resection. According to Lanier-Mankada, in the speech on the Congress Russian Association Urology 2017, efficiency of the revascularization of the penis made for medical grounds is 85% during the first 3 years of observation to 75.5% during the 5 years of the observation. What is important confirmation of necessity, the enhancement as the medical grounds for such suggested as the techniques of the implementation, the surgeries. On this slide, there are recommendations of colleagues from Belarus with use two-phase approach. The first phase is recovery of iliac arteries if there is reducing of diameter. If there is not, it calls the revascularization promptly. Our algorithm of the criterion of including doctor's appointment, get-urine anamnesis, get-urine working, social, family anamnesis, filling particular inventories, laboratory researches, hormone profile, biochemical analysis of blood, instrumental researches, pharmacodoplerometry, KT cavernosography and angiography, ultrasonic scanning of penis. The criterion of including age from 80 to 40 years, Erectile dysfunction more than 1 year, arterial or arteriovenous type without a blood down through crus. The erectile dysfunction without somatic pathology, sugar diabetes, arterial hypertension, erectile dysfunction without fibrosis of the cavernosus. As Rone de Palma said, for the best result from common number of candidates for the revascularization of the penis can be chosen only 2 persons. We worked as the method of extraperitoneoscopic revascularization of the penis with antegrade connection of the inferior epigastric artery to the deep dorsal vein. The main advantages of the method: small invasion, minimal cosmetic defect, short time of rehabilitation. Using the method of antegrade connection of the inferior epigastric artery to the deep dorsal vein keeps natural sanguinary stream, what reducing change of thrombosis, the anastomosis. Dear colleagues, I want present the
A longitudinal section on the penis gives access to the deep dorsal vein. We see the dissection of the fascia of the buck and access to the deep dorsal vein. After mobilization, a deep dorsal vein is taken on the vascular stump. The stitch is superimposed distal to the perforating vessels. Further, proximal to the perforated vessels, the deep dorsal vein is ligated. It is worth noting that this type of operation was proposed by us for the first time. All currently existing methods implied a retrograde connection of the lower epigastric artery to the deep dorsal vein. Here, as you can see, we're ligating the proximal end and cutting off distally, due to which the anastomosis will overlap antegrade. In the lower third, we cut off the deep dorsal vein. Then we approach the perforating vessels as much as possible in order to mobilize the deep dorsal vein, thereby minimizing the tension of the anastomosis, which will make it possible to exclude anastomosis stenosis. You see a perforating vessel. More we cannot mobilize. Beginning of the endoscopic stage. You see the location of the trocars. We go retroperitoneoscopically. Before us immediately appears the lower epigastric artery and combinative veins. Further, with the use of ultrasonic energy harmonic, the lower epigastric artery and the combined vessels are mobilized. Mobilization is carried out as far as possible from the artery so as not to cause trauma to the artery, which can lead to stenosis and ineffective operation. After mobilization, clips are superimposed on the distal end of the lower epigastric artery, and according to the standard procedure, the artery intersects between the clips. After cutting off the lower epigastric artery, a tunnel is formed. The lower epigastric artery is captured and discharged into the wound. After extraction of the lower epigastric artery, we do not leave any drains. This is absolutely unnecessary. Next, an anastomosis is applied between the lower epigastric artery and the deep dorsal vein. As we have said, anastomosis is superimposed antegrade. I repeat once again that this technique was developed by us. A patent application has already been filed. This technique is justified by the fact that in some cases the deep dorsal vein has a valve mechanism, and the connection of a retrograde anastomosis can lead to valve blockage and anastomotic thrombosis. In the same technique, this is excluded, and it allows you to achieve better results in the early and late postoperative period. The anastomosis is superimposed with monofilament filament 80 under optical magnification. The anastomosis is superimposed with interrupted sutures. The advantages of this technique can also be attributed to the fact that the length of the secreted deep dorsal vein is longer than with the classical technique. It often happens that the length of the lower epigastric artery is relatively short, and this caused technical difficulties in the application of the anastomosis, and the resulting is tension. With this technique, a deep dorsal vein unfolds, thereby reducing tension when anastomosis is applied. After the application of a vascular anastomosis, the practicability of the anastomosis is checked. We see that the anastomosis is passing.
And we got following results. From 2018 to 2021, we had 32% who got retroperitoneoscopic revascularization of the penis with antegrade connection. Time of the surgery was 18.5 minutes. 19 patients had spontaneous and adequate erection at the first day. 11 patients had spontaneous and adequate erection at 2-4 days after the surgery. During phase of observation, it noted 2 cases of non-efficiency of the retroperitoneoscopic revascularization of the penis with antegrade connection. In the both cases, it is the blood down true cross. And so our conclusions. For the right choice of the method, the surgery, correction, and getting maximum effect is the learning the pathogenetic causes led to erectile dysfunction. The revascularization of the penis is an efficiency method of the treatment the vessel erectile dysfunction. Worked on the method of revascularization by our center, considering follow of previous method is the least invasive one and has the last number of the complication. Thank you for your attention, and thank you my team for support.
So I have one question. Did you have any publications on this report? On this technique?
Yes, we had we have a publication in a Russian journal, and we had a publication in a Russian journal of urology. It is a journal with good shown in world.
The patients who doesn't get result after the surgery, so they will undergo for penile prosthetics?
Yes, it's patients who don't want penile prosthesis and who have small age. And one my patient read in my article. A patient was from Czech Republic, and he coming in my clinic, and now we have a good result after surgery.
Okay, I understand you. So Pavel, thank you for your kind presentation, and it is very good and very informative. And in future, if we will have any comments or any questions, so we will ask you on direct. So thank you, Pavel, for your presentation. So we have in audience, we have one question for Pierre. I have one question. So which device do you use in your practice for shockwave therapy in your patients?
Okay. So this is a very large argument because there are a lot of devices, but we have only to advise to our therapy, to our patient, device that made a focal therapy and a focal shockwave therapy. For example, Storz device, it's the better because there are a lot of published article that it's work. Or MTS, it's another. Wolf, there are only a little evidence in literature, and MedSpec. MedSpec, there are some article published by Joran Vardi that it's work, but other kind of shockwave therapy, for example, radial shockwave therapy, it's not work. So we have to use only focal therapy and only with and only this kind of focal therapy. Storz, it's the better. MedSpec, it's a little. It's not an important kind of shockwave therapy. Like MTS and like an MTS and Wolf. Other kind of shockwave therapy, we don't have to use other kind of shockwave therapy because there are no published article.
Thank you. Thank you, Pierre, for your answer. So I have another question. It's especially for Pavel. So what do you think the results of the laparoscopic and open surgery for grafting of vessels, are they similar?
Thank you for a good question. Better result after laparoscopic techniques. Why? When we use laparoscopic techniques, we had small pain, and when we have open techniques, we have many pain after surgery, and we use drugs. When we have pain stimulation, vasospasm. And vasospasm, it's not good for anastomosis. It's very high risk for thrombosis, anastomosis. And my answer, laparoscopic techniques, it's better for this surgery.
Thank you. So to finalize our today's meeting, it was very great meeting, and I hope this webinar will help to our colleagues who are interested in this area of urology to develop, to continue their practice and their knowledge. So I would say very thank to our speakers, Dr. Pavel Kizlasev and Dr. Pierre and Dr. Banga and Dr. Vladimir Kojovic. It was very great demonstrative presentations from you. So thank you, all of you, and thank you to our supportive team of Bridge International, our IT management, and our organizing committee. So we will extremely continue our webinar series in all kind of topics in urology. So thank you, all of you. See you next time.